Good evening, everyone. It's my pleasure to be here today to talk about advances in clinical care and clinical trials in ALS. My name is Doreen Ho. I am Assistant Professor of Neurology and Program Director of Education at the Sean M. Healey and AMG Center for ALS at Mass General Hospital. These are my disclosures. Today, we are going to talk about updates in ALS clinical care as well as clinical trials. As many of you know, ALS is a clinical diagnosis, and the hallmark of the disease has always been noted to be painless and progressive weakness. This is likely a very simplified notion of the disease, as there can sometimes be pain and sensory symptoms and non-motor symptoms. There can unfortunately still be considerable delay with time from symptom onset to diagnosis for patients, on average 12 to 14 months, due to a number of factors, including access to healthcare and ability to expedite workups. There is also considerable variability in the way patients present and their disease course, with sometimes slower progression or more rapid progression, differences in terms of region of onset, and differences in non-motor symptoms. The understanding of the natural history of the disease as well as the mechanisms have evolved over time, and new therapeutic targets are being developed for clinical trials. Unfortunately, at this date, there is no known cure for ALS. As of today, there are 4 FDA-approved medications for ALS. These are riluzole, edaravone, and co-formulated sodium phenylbutyrate and taurursodiol, which we'll discuss further. And in addition, as of last week, tofersen, also called Qalsody, was approved for SOD1 ALS. In terms of the clinical care for ALS patients, it's been really essential to have a team approach, and a multidisciplinary clinic allows for different members with different subspecialties to work together. The guiding principle is putting the patient and their families and caregivers at the center, and understanding that decision-making will be very dynamic and evolve over time. And the goal of the clinic is a very high level of responsiveness to the patient and the caregiver's evolving needs. Patient-centered decision-making for ALS patients is complex and changes throughout the course of the disease progression. The multidisciplinary approach allows the different subspecialties to collaborate with one another and support the patient through the decision-making process, through decision implementation, and at different stages of the disease, with frequent circling back and reevaluation. This slide represents the different subspecialties involved, including pulmonology, pain, psychiatry, orthopedics, genetic counseling, and palliative care. Access to research trials and community resources and advocacy can also be bridged via the multidisciplinary clinic. Education and engagement become crucial elements of the multidisciplinary model so that patients and caregivers can make informed decisions. And as we'll discuss in this talk, new targets and therapies are emerging to innovate the pathway to slowing disease progression for our patients and ultimately for finding a cure. I want to talk a little bit about symptomatic management and emerging therapies in symptomatic management. At the heart of the multidisciplinary clinic is symptomatic management and addressing the patient in a holistic manner. There have been improvements in symptomatic therapy and in multidisciplinary care, and different treatments in terms of treatment of fatigue, pseudobulbar affect, which is emotional lability, sialorrhea, or if a patient has drooling or some secretions, treatment of cramps, treatment of pain, mood, spasticity or increased tone, and trouble swallowing if this applies. Augmentative and communicative devices and technologies are also rapidly evolving. And discussions with regards to goals of care are evolving, with an emphasis again on multidisciplinary approach and dynamic patient-centered care. And increasingly, there has also been attention toward increasing access to multidisciplinary clinics and to clinical trials for patients in different parts of the country and in different parts of the world. I want to just highlight one emerging therapy and novel therapy in regards to symptomatic therapy in ALS. This drug, dextromethorphan hydrobromide and quinidine sulfate, was approved by the FDA in 2011 for labile emotionality, or PBA, pseudobulbar affect. It has been studied in the New Dexter trial, where 60 patients with ALS received, in this design, as you can see in this figure, basically received either New Dexter or placebo with a washout and then a crossover. One of the main scales was a self-report measure called the Self-Report Center for Neurologic Study Bulbar Function Scale, CNS-BFS. And overall, CNS-BFS scores improved during the drug arm as compared to the placebo arm, and for the subdomains of salivation, speech, and swallow. In the bulbar subdomain of the ALSFRS, 49% of patients on dextromethorphan hydrobromide and quinidine sulfate improved by greater than or equal to 1 point versus 26% on placebo. So this showed overall good evidence that this medication can help, in addition to pseudobulbar affect, can help with swallowing and speaking. And in a follow-up study looking at physiological measures by Gray and colleagues, there was more recently an assessment of bulbar symptoms with Nuedexta with measures other than just patient-reported outcomes. In this study, 28 patients enrolled and 25 patients completed a 30-day protocol, and there were improvements in the bulbar subscore of the ALSFRS, improved duration of uninterrupted speech, and improved swallowing. So this is one medication that is increasingly used in the multidisciplinary clinic for chewing and swallowing and speech. Let's turn our attention to the FDA-approved disease-modifying treatments in ALS. As mentioned, currently 4 FDA-approved treatments for ALS exist. We will talk about tofersen slightly later in this talk. The 3 that we'll talk about now are riluzole, which was FDA approved in the United States in 1995, edaravone, which was approved in the IV form in 2017 and in the oral form in 2022, and sodium phenylbutyrate taurursodiol, which was approved in 2022. It is important to mention that cost and access remain significant factors in clinical practice, in particular with regard to edaravone and sodium phenylbutyrate and taurursodiol. It is also important to mention that these 3 medications can be used concomitantly and synergistically in our patients. The first FDA-approved medication is riluzole. This is the oldest FDA-approved medication. Its mechanism is that it is postulated to antagonize glutamate-induced excitotoxicity, although the exact mechanism of neuroprotection is not known. Based on the data, it's fairly clear that riluzole does have a survival benefit in patients with ALS. In the first of 2 pivotal trials, 155 patients with ALS were randomized to riluzole, 100 milligrams a day versus placebo, and time to tracheostomy or death was longer for the patients who received the riluzole, with a median difference of 90 days. In the second pivotal trial, 959 patients with ALS were randomized, and this also confirmed increase in survival. A retrospective clinical staging analysis did reveal that the treatment with riluzole prolonged survival at the late stages of the disease, stage 4. And this diagram shows the data from this study, which shows that here you see the green line, which is riluzole at 100 milligrams a day versus placebo. And you can see that the curves spread, but this is when the patient is in an advanced stage of their ALS versus the treatment of riluzole did not significantly prolong time in stages 2 and 3, or 3, unfortunately. So how is riluzole used in clinical practice? Well, in general, it's initiated early after discussion with the patient. The drug in general is well tolerated without major side effects. It could cause a drug-induced liver injury or asymptomatic elevation of AST and ALT, and therefore, typically, we will monitor AST and ALT monthly for 3 months and then every 3 months. There have been reports of neutropenia within the first 2 months, so we usually do monitor the CBC as well. In general, it's been accessible for patients, especially as well as from a cost standpoint. And as mentioned, it can be initiated early in the disease. It's an oral medication taken twice a day. The second FDA-approved disease-modifying treatment is edaravone. The mechanism of action is that it's a free radical scavenger to reduce oxidative stress. It was originally approved in an IV form, and then based on studies of bioequivalence, was approved in a PO form. A phase 3 trial showed slower decline in the ALS-FRS, so the functional rating scale, with edaravone in patients with earlier stage disease and with definite or probable ALS. So that's based on the revised Ellis scoring criteria. In this study, survival was not evaluated. Follow-up prospective randomized control trial of patients with early and definite and probable ALS showed slower decline in the ALS-FRS in the edaravone group versus placebo. However, a recent multi-center propensity score matched cohort study showed no impact on survival. So this shows in the study, the first sort of study that I mentioned, the slope and change in ALS-FRS in the edaravone group versus the placebo group, and shows the slower decline in the ALS-FRS group, in the ALS-FRS in the edaravone group versus placebo group, again, in patients who were earlier in their disease and also with definite and probable ALS. So based on these results, edaravone was approved by the FDA. It was approved, as mentioned, in an IV form prior to being approved in a PO form. These days, it's typically given in the PO form, which can be administered orally or, if needed, via a G-tube. In general, it's well tolerated. Side effects have been reported that include gait disturbance, headache, or if it's delivered IV, you could have contusion at the site of the IV. As mentioned in our clinical practice, typically the by-mouth form, which is an oral suspension, is prescribed. Cost and access and insurance approval have been issues for some patients. And it's been noted that it should be used in caution in patients with asthma, particularly severe asthma. Let's turn our attention towards the newest FDA-approved medication aside from tofersen, and this is sodium phenylbutyrate taurursodiol. This is a co-formulation. The sodium phenylbutyrate reduces endoplasmic reticular stress, whereas the terso improves mitochondrial membrane integrity. This is a powder which is dissolved into water and then may be administered orally or via a G-tube. FDA approval was based on the results which were positive from the phase 2 Centaur study, which demonstrated slowing of ALS-FRS decline with a 2.32 absolute difference between the two groups at 24 weeks, which is a significant difference. In addition, a long-term study in follow-up of the same patients found a survival benefit of 6.5 months. And based on this, the sodium phenylbutyrate taurursodiol co-formulation was approved in 2022 and is now prescribed in clinics. And this shows the difference in median survival duration of 6.5 months in the Centaur patients in follow-up. In general, sodium phenylbutyrate taurursodiol in clinical practice is also a safe medication. In general, GI discomfort has been the most common side effect. This can be diarrhea, abdominal pain, or constipation. At our center, most cases, but not all, have been self-limited. Sometimes over-the-counter treatment is required, and occasionally the patient may require dose interruption or reduction. In addition, it's been noted that the salt content is high. It can cause fluid retention and must be used with caution in patients with kidney disease or heart failure. As with edaravone, cost and access have remained issues in clinical practice. So to summarize, in clinical practice, the standard of care has been use and synergistic and concomitant use of the 3 disease-modifying FDA-approved treatments, understanding that unfortunately cost and access have continued to be issues for some of them. We will later discuss tofersen for SOD1 ALS. Let's turn our attention now to the new developments in research and clinical trials in ALS. So with increasing understanding of the disease, it has become clear that no 2 patients with ALS are the same, meaning that the disease is very heterogeneous. And this is a very important concept because approaches to treatment, care, and clinical trials must be highly individualized as we move forward. And this slide just shows that there's heterogeneity in terms of the genetics of ALS, in terms of the biology and mechanisms of ALS, and as well as the clinical features of ALS, how patients present. In terms of the genetics of ALS, familial ALS accounts for 10% of all patients with ALS. For a particular patient with ALS, having concomitant frontotemporal dementia or a younger age of onset does make it a higher likelihood of a positive mutation. And now greater than 50 genes have been identified, with the 4 most common being C9orf72, which accounts for 32% of patients with familial ALS, SOD1 accounting for 11%, TDP43 accounting for 4%, and FUS-TLS accounting for 3%. So patients with, for instance, SOD1 mutations account for 2% of all cases of ALS. When a causative gene is identified, then these patients do share a target for potential investigational treatment options. However, many patients with ALS do not have a known genetic mutation, and there's clearly an interplay between genetics and environment that play a role in the development of ALS. I should highlight here that genetic counseling is a key part of the multidisciplinary model and is an important part of the process. Can occur pre-genetic testing or post-genetic testing, and is very important as processing the results can be very stressful and very complicated. In addition to the possibility of a positive result or a negative result, the patient can also have a result that's a variant of uncertain significance. And if a mutation is detected, genetic counseling is also very essential for counseling of the patient as well as for family members. In clinical practice, genetic panels are available at the clinics through different programs, such as prevention genetics, to do the panel of genes. Let's talk a little bit about the biological heterogeneity in ALS. So the exact cause of ALS in sporadic ALS or non-familial ALS remains unknown. Multiple cellular mechanisms contribute to degeneration of the motor neurons. The genetic abnormalities clearly play a role in familial ALS and possibly in sporadic ALS as well. And oxidative stress, axonal degeneration, aberrant mRNA processing and transport, neuroinflammation, synaptic dysfunction, endoplasmic reticular stress, and dysfunction of the mitochondria converge, and the final pathway is upper and lower motor neuron death. Discovering the mutations in the genes has also led to insights in regards to these mechanisms, and drug development is also aimed at targeting these mechanisms. This slide shows that there can be quite a bit of clinical heterogeneity in ALS patients, meaning that no two patients are the same in terms of how they present and how they progress. There can be differences in terms of site of onset, in terms of rate of progression. Some patients may have more upper motor neuron signs or lower motor neuron signs. There's differences in ages of onset and ethnicity. And there's also differences in terms of whether or not a patient has been exposed to a disease-modifying treatment. So in clinical trials, there have been measures to address the heterogeneity of the population, and there has been developments in terms of outcome measures, biomarkers, as well as prognostic models. So just to give you a little bit of a sense of the outcome measures that are very much evolving. So currently and historically, the ALS-FRS, which has been mentioned quite a number of times, so the ALS Functional Rating Scale Revised, is the most widely used outcome measure. This is a functional rating score. It's self-report. It has a maximum score of 48 points, and it has subscores in different domains like bulbar, which is chewing, swallowing, speaking, fine motor, gross motor, and also respiratory domains. It's been noted that the ALS-FRS is not linear, and it has some setbacks, such as some patients, setbacks for the purposes of trials, such as that some patients don't have a decline over 6 months based on that scale. And also it has some questions that show improvement with symptomatic treatment in ALS. So due to the limitations in trials in regards to the ALS-FRS, Dr. Fournier from Emory more recently developed the ROADS, which is a 28-question self-report, which has high retest reliability and is linear weighted. So that means that 1 point change is consistent. And that's being tested in current and future trials, including regimen F of the HEALEY platform study. So there's been development in terms of outcome measures. This also lists some other outcome measures that are used currently in trials. And biomarkers are under development and are hugely important in clinical trials. Collection of biomarkers is also essential to understanding the natural history and to drug development. And biomarkers are being developed in the serum, the cerebrospinal fluid, and the urine. And this sort of highlights why sometimes examination of this cerebrospinal fluid with a lumbar puncture is very essential in certain trials due to detection of the course of different biomarkers. There are also imaging and electrodiagnostic, meaning like EMG biomarkers that are being developed and validated. This figure depicts the different targets for different medications. Some of them here are the FDA-approved medications and also the certain investigational agents that are used, that are being studied in different trials. The different medications can also be used, as mentioned, the different FDA-approved medications can be used sort of synergistically to promote overall improvement in neuronal function. And here you can see the ASO for SOD1 was just FDA approved last week. And we'll talk more about these. So these are examples of some of the clinical trials that are enrolling in the United States. We'll talk a little bit more of the design of the platform study because it's a novel design. The mechanisms of action of the investigational products are quite different. Here is a The Nadal's basket trial, the neurodegenerative Alzheimer's disease and amyotrophic lateral sclerosis basket trial, is studying a JAK1 inhibitor, and it's a phase 2 trial, 6 months open label extension. Sanofi's Himalaya trial is studying a RIPK1 inhibitor, and a different design with 6 months randomized control portion and 6 months open label extension. And the Calico study, phase 1B, is studying an EIF2B activator, which attenuates the integrated stress response, and it has a 4-week randomized control portion and an active treatment extension of up to 152 weeks. And the HEALEY platform trial is phase 2/3 with multiple regimens, with a shared placebo, with a 6-month randomized control portion followed by open label extension. So these are just sort of examples, and we'll talk about some of the different targets and some of the different pathways as well. There are many, many trials currently enrolling in the United States, and these are just a few examples. Neuroinflammation is a key pathological process in ALS. This is characterized by activation of microglia, infiltration of monocytes and T cells, and astrogliosis. And there are multiple potentially key pathways. The RIPK1 pathway, receptor interacting serine threonine protein kinase pathway, the JAK signaling pathway, Janus kinase signaling pathway, and also activated glial cells, to name a few. And in addition, there are sort of emerging ALS therapies that are being studied: antisense oligonucleotides, mesenchymal stem cells and T regulatory cells, and antiretrovirals and small molecules. And these are all sort of in development. So antisense nucleotides are single-stranded DNA with 10 to 50 base pairs, and they bind to target DNA. They're appealing because they alter gene expression precisely, and the host DNA is preserved. Antisense oligonucleotides have been approved for treatments of other conditions, including spinal muscular atrophy. They've been designed with very high affinity and stability, and they work through a mechanism of RNase H-dependent cleavage. And basically, the idea is overall that they neutralize a mutant or toxic gene product or protein associated with ALS gene mutations. As mentioned, they have had previous models of being used for other diseases, such as Spinraza for the treatment of spinal muscular atrophy, and have been safe and well tolerated in that setting. They are approved for over 10 conditions. And last week, tofersen or Qalsody was approved for treatment of SOD1 ALS. So this further depicts what an ASO does. It basically modifies the protein expression without changing the host DNA. Of note, the ASOs have to be delivered intrathecally, meaning that they have to be delivered via a lumbar puncture because they don't cross the blood-brain barrier. So once into the cerebral spinal fluid, they're taken into the cell, as this figure shows, and into the nucleus. They then bind to the gene target that creates this hybrid RNA DNA, and that recruits this enzyme shown here to cleave the RNA. This schematic on the right of the slide does not represent the exact binding sites, but gives you a sense of the ASOs for the different mutations in ALS. These are examples of current trials that are studying ASOs and their targets in ALS, in the different ALS associated with different gene mutations. In terms of tofersen, it's worth talking about, especially with the FDA approval last week. Basically, in this study, intrathecal administration of tofersen versus placebo was administered over 24 weeks, followed by a 4 to 8 week follow-up period and an ongoing open label extension of up to 230 6 weeks. There were 2 patient subgroups, the faster progressing patients and the slower progression patients. The primary endpoint was change in ALS-FRS from baseline to week 28 in the faster progressing subgroup. And secondary endpoints were changes in SOD1 protein and CSF, and also concentration of neurofilament light. There was no change, as you can see in this table, in ALS-FRS, but within the faster progressing group, tofersen decreased CSF SOD1 as well as plasma neurofilament light chain. The slow progressors had trends towards similar, but they didn't have as dramatic reductions. And in the fast progressing group, tofersen showed trends toward benefit in breathing or slow vital capacity and also muscle strength, with differences shown most in the open label extension. And I think also more data even will emerge from that. So as of this week, tofersen can be prescribed in the setting of ALS associated with SOD1 mutations. I also wanted to mention an update on mesenchymal stem cells in ALS. So a phase 2 study of bone marrow-derived mesenchymal stem cells in 48 patients had a primary objective of safety. And the safety objectives were all met with no treatment-related serious adverse events. There were adverse events related to delivery, but these were very transient. Amongst the fast progressors, a higher proportion treated with the mesenchymal stem cells had greater than 1.5 point per month improvement versus placebo. And CSF markers of inflammation decreased after transplantation of stem cells. CSF monocyte chemoattractive protein levels correlated with improvement of ALS-FRS slope for up to 6 months. In a phase 3 trial, which was a multi-dose phase 3 study of 196 patients, the primary endpoint was the rate of change of the ALS-FRS per month. It was, in general, well tolerated and safe. And there was no difference in the primary endpoint, which was the rate of change of the ALS-FRS per month, but there was improvement in the biomarkers of neuroinflammation and neurodegeneration, so improvement in the biomarkers of VEGF-A, neurofilament light, and MCP1, importantly. These figures show that improvement in these biomarkers over time with mesenchymal stem cells. The blue here is the group that was treated, and the red here is the placebo. In addition, the integrated stress response has been postulated to be a key pathway in ALS. Dysfunction in the trafficking of proteins and the RNA between the nucleus and the cytoplasm is likely a very important mechanism. In patients with C9orf72 mutations, the most common mutation associated with familial ALS, these trafficking issues occur. So activation of the integrated stress response, which is chronically activated in ALS, leads to formation of stress granules from mediators of transport between nucleus and cytoplasm. Therefore, 2B activators which attenuate the integrated stress response are of therapeutic interest in ALS and currently being studied in phase 1B as well as the HEALEY platform study. Additionally, there's been a long-standing interest in the role of antiretrovirals in ALS. There are elements in our genome which are transposable elements, and the majority of these are retrotransposable elements. So basically, areas of the genome that are usually inactive or silenced, but in certain disease states they become active. And over time, both preclinical and clinical studies, so studies on humans and animals, have detected that retrotransposable elements have increased activity in ALS. So there are different studies looking at ways to basically try to silence this activity in patients with ALS. So this is another area under development. There's also been quite a bit of innovation in clinical trial design. So clinical trials are being designed in conjunction with novel biomarkers that are sensitive to change. And the idea is to try to have faster and more patient-centered trials that can help more patients and also can develop a deeper understanding of ALS. And so the HEALEY platform study is a first of its kind type of trial design in ALS. It is perpetual and it is adaptive. So in a traditional clinical trial, basically the structure or infrastructure needs to be built each time a trial is created. So this takes time and resources. However, in a platform study, which is a type of design previously used in oncology, the same structure is used for each therapy that is brought for testing at the phase 2 level. And the idea is that it can quickly and efficiently test different drugs and see which ones can then proceed to phase 3 testing. In addition, it's patient-centric in that the placebo can be shared. So fewer patients will be randomized in the first portion of the study, which is the randomized controlled portion, into the placebo group. So in this trial, for every 3 patients who is on an active investigational product, 1 patient will have be on a placebo. And that's a smaller number or fraction than is in most standard trials. So this slide shows the structure of the HEALEY platform study. So this is what it means that it's perpetual and adaptive. Basically, as new drugs come in and they're vetted and have good science, they are brought in quickly and they can be studied in parallel. And at this point, regimen F is enrolling, and regimen G, which is which the sponsor is Denali, and it's also an agent that acts on the integrated stress response. The regimen G will be also brought in. This slide represents regimens A through F. 2 regimens have gone on to phase 3 testing. 2 had negative results. And in addition, as new biomarkers that we've talked about and outcomes are studied, they can also be very added in sort of quickly into this sort of known existing infrastructure. So for instance, for regimen F, which is ABBV CLS 7262, the Rhodes outcome measure can be utilized and tested. So this allows for very efficient testing of drugs and also inclusion of new biomarkers and outcomes. So the end result in terms of the trial design is that it does cut the time in half. It cuts down the cost, so it makes it more efficient, therefore allowing for more sites to be involved and more efficiency. And then there's a reduction of the placebo. There are multiple sites in the U.S. that are participating in this platform study, and this is led by Dr. Sokovich and Dr. Paganoni. So in conclusion, multidisciplinary care is, as mentioned, the standard of care for caring for patients with ALS, requiring a very collaborative team approach to meet the evolving needs of patients as their disease progresses. Symptom management, anticipatory guidance, and discussion and initiation of FDA-approved medications, genetic counseling, and also clinical trial discussion are key goals of the multidisciplinary clinic. The fact that there's a lot of heterogeneity, clinically, biologically, genetically, has posed some challenges in clinical trials, and this is actively being addressed and better understood as we move forward. 4 FDA improvements can slow the progression of disease. And in general, clinical trials are evolving and growing to quickly target the mechanisms that do converge to lead to motor neuron degeneration in ALS. Biomarker discovery, gene-directed therapies, and innovative trial designs such as the HEALEY platform study are exciting and evolving areas in ALS innovation therapies. So that concludes my talk and leaves room for some questions. Thank you very much for your attention and participation tonight in this webinar. As always, my deepest gratitude to the patients who participate in our trials, who are seen in our clinic, and allow us to care for them, their caregivers, and their families. Also, my gratitude to the MDA for hosting this, the HEALEY Center at MGH, and the NCRI. Thank you.
All right, thank you so much, Dr. Ho, for sharing that information. A lot of wonderful updates and information. So we are going to have a few minutes here for some questions and answers. If you all want to use the chat feature to type in any questions, you can do that. We actually did get a few questions sent in before the session via email. So one of them is, what should I know about how ALS affects other health problems and how other health issues affect ALS?
That's a great question. And there are many ways to think about that. You know, we usually do discuss this with our patients and do, you know, get to know who the primary care of our patients are, because sort of throughout the process and throughout the journey, there are sometimes things that can be addressed with the primary care and partnered with the primary care. So I think, you know, other medical conditions are very important to keep in mind. And there are different ways that other medical conditions can intersect with ALS. First, there are times when side effects from medications can interact with medical conditions. So if a patient has like pre-existing a liver condition, that would be really helpful to know, because as mentioned, you know, ribosol can have effects on the liver. Certain medications, you know, can also interact, for instance, with Relyvrio. If a patient has heart failure or hypertension, it would be helpful to know in consideration of the salt content of Relyvrio. So that's one way that sort of the different domains can intersect. I think also, in addition, you know, often the primary care sort of allows us as ALS clinicians a certain window into the sort of the patient and their family and their healthcare overall over a very long term, because, you know, sometimes I'm meeting someone, you know, at a certain point, but I'd be curious to know historically how the patient has been, and you know, what are other issues that have come up. So I think it's very helpful. And then another reason that you know, other health conditions can be very important is in the context of a clinical trial. So there are certain medical conditions that are unfortunately not sort of like excluded and would make a person not eligible for a clinical trial. That's usually because it's maybe not safe, you know, for the patient to be included in the clinical trial with that medical condition. And so it's very important and very helpful to know that. And then I think, you know, as different subspecialties in the ALS clinic are brought in, say, for instance, there's the need for a pulmonologist. it can be very helpful to know about the patient's prior pulmonary history, if that's applicable, or anything, anything else related. So I think overall, it is really important, and it's really important to partner with the other, people who have cared for the patient, to make sure that, we're really sharing the information and really collaborating, even if the primary care physician is not at the same site, or a family practice doctor or another provider is not at the same site. These days, luckily, health information is more easily shared, via the electronic health record, and usually it's a phone call or something like that, or telemedicine that can be used as well. So
great, thank you so much. Somebody else has asked about fatigue. What should people with ALS know about fatigue? I seem to get so much more tired lately.
Yeah. So it's in general a very common, probably the most common symptom in ALS, and it's probably due to a number of different reasons, and it can also intersect with a number of different conditions. For instance, sometimes someone will report being fatigued, and they will also report that their mood is down, and so sometimes one could cause the other. But in general, fatigue is very common, and there's an increase in catabolism in this condition, meaning there's a lot of energy being burned, and so that results in fatigue. There are other reasons for fatigue as well. For instance, if someone's not sleeping well, and that could be from a number of different reasons, but it could also be if they're not oxygenating well at night. That could occur. Breathing issues in general in ALS could lead to fatigue. So I think probably the take home is that it is very common. It's very important to talk about it with your team, your ALS team, because sometimes you can detect that maybe there is a little bit of difficulty bringing air in and out, and it's manifesting as fatigue, or maybe it sort of uncovers that maybe there was a change in mood, or something related to mood, or again, different factors. So while I don't think it may not be easy to tease out, it's important to bring out so that your team can help you to tease out maybe some of the factors. And so usually in our clinic, we'll try to get at what are the causes of it. And often it's not just one cause, it could be multifactorial. Perhaps do some testing to see if those causes are the reasons for it, and then try to treat the underlying cause. We don't often use like stimulants because it's typically more about treating the underlying cause. But very, very common and very important to bring up with your care team.
Okay, thank you. Somebody has asked about reading a lot about different vitamins and herbal remedies and supplements that help maybe slow ALS, and they all look really promising. Do you have any words of wisdom or advice about those?
Mm-hmm. So there are quite a number, and it can be quite overwhelming. And in general, my approach is that, and I think it's shared by the other members of the HEALEY Center, is that if it's not harmful, the first thing is making sure that it's not like a harmful supplement. But if it's not harmful, being very open-minded to it. There are a few things to consider, though, when considering supplements or off-labels. The first is definitely, asking, is there a downside or a risk or a cost? There are a lot of them as well. There are some clinical trials that do not allow for certain supplements or off-labels. So I think it's usually important to talk to your care team before starting any of them. And the data around, different off-labels is quite varied. Some of you may have seen the website ALS Untangled, which summarizes some of the data in regards to the different types of off labels. So there are a lot of them out there, and they have quite a sort of a variety of in terms of how much data that they have and what the data are. And again, I think looking at it through the lens of making sure that there's nothing harmful, I think is very helpful. I think that most of the time in our clinic we definitely hone in on the FDA approved disease modifying treatments, but then we do on occasion use off-label medications in certain contexts as well, so we keep an open mind to it as well.
All right. Thank you so much, Dr. Ho. Those are actually all of the questions that we have. I don't see any more that have come in. So let me do one more check. Nope, I don't see anything. So we so appreciate your time, Dr. Ho, your expertise and everything you do for the neuromuscular community. We really, really appreciate you being here and sharing this wonderful information.
Thank you so much.
I would like to thank our webinar supporters, Cytokinetics and Mitsubishi Tanabe Pharma America. We would not be able to provide community education webinars like this if not for their generous support, and we're very thankful and appreciative. If you're new to MDA and are diagnosed with a neuromuscular disease under MDA's umbrella or are a loved one of someone who is diagnosed, we encourage you to stay engaged with MDA. You can do this by visiting mda.org/join and completing a short form. Joining is free and will keep you up to date on the latest research, educational programs, and supports. We would love to hear your comments about this webinar. If you have a smartphone, you can open your camera and point it at the QR code on the screen. That'll pop up a web page with a short survey on today's webinar. If you don't have a smartphone, once the webinar is over, a screen will pop up with a survey as well. If anyone has questions after this webinar, please feel free to email them to mdaengage@mdausa.org and we will follow up with you. This concludes week 1 of the ALS Virtual Learning Series. Thank you very much for attending and we hope to see you next week. Thank you. Have a good evening.